Hey, I'm Randy Helm, the president of Muhlenberg College, and we couldn't have picked a more appropriate time in the life of our country and in the development of healthcare delivery to have this distinguished panel as moderated by one of our most distinguished alums. Things are changing almost hourly, it seems. And so if these folks can help us peer into the future, that will be, I think, something we're all going to be very interested in. This is an appropriate venue for an event like this because, as I think most of you know, Muhlenberg has for generations been a mecca for pre-meds who want to go into health professions. They come here, they do their undergraduate work, and typically we have a very high acceptance rate to some of the best medical schools, dental schools, and other health professions throughout the country. And I was told that here in the Lehigh Valley, hundreds of the physicians in the Lehigh Valley got their undergraduate degrees, their undergraduate training at Muhlenberg. And throughout the state, it is multiples of that. And I think what's particularly important to remember is those people didn't all grow up in Pennsylvania. They came to Muhlenberg from all over the country, and yet they stayed here. So we are not a brain drain, but a brain magnet. And we bring them, we train them, they get to know just what a great place Pennsylvania is, and especially the Lehigh Valley. They get their advanced training and they stay and they deliver excellent health care. One of the things that a college like Muhlenberg has to do to continue to bolster that reputation is to continually invest in facilities, to innovate in programs, to hire top-notch faculty, and to adapt teaching strategies. And so over the last decade since I've been here, we have done all of those things. We have built a new science building. We've renovated our old science buildings. Our oldest one is almost 90 years old, a Trumbauer building where chemistry and math and physics hold forth. And we've doubled the size of the Shankweiler building with an addition. And we have increased the size of research labs to the faculty. Faculty now can do independent research with students, with undergraduates, and often they do publish papers in collaboration with our students. Almost all of our students who go on to health professions have already done research with the faculty here, and that's been a very powerful pedagogical innovation for us. We also have launched new programs over the last 10 years. The first one, and I've been here a little over 10 years, and I don't take any credit at all for either of these, but the first one was launched simultaneously with my arrival, and that was our program in neuroscience, which is now one of our largest and fastest growing majors, and the other is our minor in public health, which I believe, unless somebody has caught on to the importance of this field, that we are the only public health minor in the Lehigh Valley, or public health major either, for that matter. So, and we are hoping to look at upgrading that minor into a major sometime soon. Very important field. Now, that's enough about Muhlenberg. It's never enough about Muhlenberg when you get me up in front of a microphone, but I realize that's not why we're here. You're not here to hear an infomercial for Muhlenberg. But there is one other thing that Muhlenberg can take particular pride in that I do need to mention, and that is the moderator of tonight's panel, Ray Singer. Ray is a member of the class of '80. He is extremely loyal to his alma mater, and his loyalty expresses itself in many ways. He has served as an associate trustee and as a trustee. He speaks frequently to science classes. He does job shadowing. He does the Day with the Doctor program. And I wanted to tell the students who are here tonight, and we do have a number of our students here, that just so that you have something to aim for, when Ray graduated, he graduated with a 4.0 GPA. He was Phi Beta Kappa, and he graduated summa cum laude. And he still had time to volunteer and to involve himself in extracurriculars. He was a Cardinal Key, and he was a disc jockey for WMUH, where he had the handle, Little Ray, your main DJ. And he's always eager and happy to talk to students. So if any of the students who are here tonight want to grab a cup of coffee with Ray tonight or some other time, he's a very friendly guy, and you should reach out to him. I would say that when I was named president of Muhlenberg in spring of 2003, one of the first letters I got from Muhlenberg alumni was from Ray Singer. And one of the first alumni I met when I came to the Lehigh Valley was Ray Singer, because he loves this college. We are really lucky that he has pulled together this very talented panel. I'm going to let Ray do the introductions, and he has a few words he wants to say, and I blessedly will not be up here, and I will not be speaking anymore. But as Ray, as I invite you up, I do have just a gift for you to thank you.
Thank you.
It is this lovely bag of tissue paper.
Thank you. Thank you.
I hope you enjoy it.
Thank you very much.
Thanks for doing that.
Thank you. Yep. Little Ray, your main DJ. So. We had a Sunday night Hall of Fame show. We had oldies. Sunday night Hall of Fame, 89.7, if I go through the whole thing for you tonight. So thank you, President Helm, for your terrific introduction and kind words. I want to welcome you all here this evening, and thank you for coming. Special thank you to Deb Kipp and our development office here at Muhlenberg College for organizing what is already a magnificent evening. I also want to show our appreciation for Medtronic, who is helping to support this great educational event. Before we get started, I would like to speak a little bit about my beloved alma mater. 37 years ago, hard to believe, but 37 years ago, my mother and father drove me here to Muhlenberg College as I became a member of the entering freshman class of 1976. And I'm honored not only to be here this evening, but I am truly blessed to be able to introduce to you the same person who drove that car 37 years ago, my very strong, my very youthful, and my very independent 90-year-old mom, Gertrude Singer. In 1976, I had a dream of becoming a physician, of going to a prestigious medical school, of working at a fine medical center, and of raising a family and living in a nice community. And I can stand here before you this evening and tell you that because of Muhlenberg College, all of my dreams have come true. After I finished Muhlenberg, I had the privilege of attending the University of Pennsylvania School of Medicine, which is one of the nation's truly great Ivy League medical schools. And I've spent my entire career, 22 years, at Lehigh Valley Health Network, which is by far one of the finest medical centers in the United States. And I've been particularly blessed to live in this diverse and wonderful community with my beautiful wife, Bonnie, and my two beautiful daughters, Lana and Julia, who are both here this evening with us. Bonnie, Lana, and Julia. I really sincerely feel I owe all this to Muhlenberg College. In my mind, college is a time when dreams begin. It's a time of great change. It's a time when we see our children become adults. It's a time of endless opportunities and great hope, not only for our students, but in many ways, as much or even more so, for their parents. I know I see a lot of parents of our students here this evening, and I see a lot of parents of students who are at other colleges, and I know that as parents, we all know exactly what I'm talking about. But there's one parent who's not here this evening, and that, of course, would be the other person who was driving that car in 1976, and that would be my late father, Alexander Singer. If you can pardon my indulgence, I wish to read to you the note that he handed to me when we shook hands and said goodbye in front of Prosser Hall for the students who are here. It was the first year Prosser Hall opened up. The actual note that he handed to me as we shook hands and said goodbye in the autumn of '76. And this is the actual note handwritten by my father. I believe that when you hear this, you'll see that it says everything there is to say about college. It says everything there is to say about family and about our hopes and our dreams for our children. It says, Ray, just a note to wish you well on your new venture. Son, I'm not going to pour out fatherly advice because I don't think you need it. I know you have your head on straight. You're pretty much on your own now, but remember this, boy. As long as I live, you will never really be alone, no matter the distance between us. Your leaving the home created a void that no one could ever fill, and that will take some time getting used to. However, I rejoice for the years you were under my wing and for the father and son relationship we had and still have, and for this, I envy no man. I guess, Ray, a guy needs a reason to keep going, and when things got a little heavy, I would look at you and I knew I had my reason. I could go on, but it all boils down to this. You can take great pride in knowing you made your old man very happy and proud. At the risk of sounding unmanly, I want you to know that no man ever loved his son more than I love you. Tuesday, September 8th, 1976. Muhlenberg College is indeed a special place. It's a place where dreams really do come true. So I would like to invite President HELM back to the podium for a moment. So I'd like to present the college with a gift. President HELM, on behalf of my family, Bonnie, Lana, Julia, we wish to give the college this gift for $10,000 in honor of my mother and father, Gertrude and Alexander Singer. Well, tonight we have a very exceptional program. It's going to be very exciting, and as President HELM said, we can't pick a better week, even a better day, if you're watching even the news today. Things are changing literally by the hour. So let me start by asking you a simple question. How many of you here already know everything there is to know about all the healthcare legislation and come up and explain it to everyone? No? I didn't think so. Well, to assist you this evening, we have amassed 5 experts. And what's interesting about this evening is that these 5 experts have a slightly different vantage point on this. And before I got up here, I actually heard a little bit of debating back and forth as to maybe just slightly friendly disagreement on what the issues are and the solutions. Each speaker will give about a 7-minute discussion about healthcare reform, how it affects their organization, their patients, and their employees. And hopefully, they'll give us a minute or so of kind of a 30,000-foot view on what they think the future of healthcare is in our region. And then at the end of the evening, we're going to open it up for a panel discussion where each of you can ask them questions directly. So let's get started. We're going to go in alphabetical order. Our first speaker is JOANNE Judge. And I guess if you're going to be a lawyer, that's not a bad name.
It's a terrible name.
Does it get confusing in the courtroom, though? Judge, yes, no, judge, sit down. JOANNE is the co-chair of the Health Law Department at Stevens & Lee Law Firm, which if you don't know of Stevens & Lee, they're truly the powerhouse in healthcare issues in Pennsylvania. Attorney Judge was the previous president of Community Hospital of Lancaster and was formerly their chief financial officer. JOANNE got a Bachelor of Science degree at St. Joe's and then your law degree at Villanova, so I have to ask you, which basketball team do you root for?
Oh, no question, St. Joe's. I'm a Hawk.
Okay. JOANNE is an expert in regulatory matters with regards to healthcare systems, including mergers and acquisitions, licensure and compliance-related issues, which is really important stuff with healthcare reform. She has served as the National Chair of Healthcare Financial Management Association. For those of us from the Philadelphia region who still get the Philadelphia Magazine, for the past 7 consecutive years, she is designated one of Pennsylvania's super lawyers. So it's my privilege to introduce to you Attorney JOANNE Judge.
Thank you. Thanks. If you'd like me to, I'd be happy to. Okay. I'll take my watch so I don't blow your time.
Okay.
I'll sneak past you. Thank you for having me. I heard Dr. Singer say we're going to each talk about the impact it has on our patients. You'll be happy to know as a lawyer I don't have any, so probably a good thing. I have been practicing, first as you heard, I work directly in the healthcare industry, and now I've been practicing law for 16 years, doing exclusively healthcare. So I think I have an interesting vantage point from the business side of it, and that's where my framework will be. The reason I hope that we understand that we're all talking about this incessantly on an hourly basis, it seems like right now, is this healthcare system in the United States is a fantastic success, and it has an enormous target on its back because it's so big, and in many cases it's become unaffordable. We spend almost $3 trillion in this country on healthcare, which, if you think about that, it would make us bigger as a healthcare system than many other countries, much less other countries' healthcare systems. And so the notion has been that we have to focus on it because it's growing too exponentially. And at the same time, if you look at some of the indicators of what the results are, they've not always been stellar. We don't have some of the best healthcare statistics of all of the developed countries. And so that's why I think there's been such conversation about healthcare for quite a long time now, and why now you see a pretty seismic shift going on in the way that we're going to both deliver and pay for care. Now, I am not going to answer the question about whether you should keep your current health care plan, even if it doesn't fit the current health care reform law, but that's an example of just how you try to push something in one direction and the details get more complicated as it goes. So I think we really have to evolve on that. If you think about the way the U.S. healthcare system evolved following World War II, it was really focused on 2 things. One was on treatment. You never heard anybody talk for the initial decades of the U.S. healthcare system about preventive healthcare. And it was focused on procedures rather than on really focusing on what are healthy lifestyles and other things. I'm old enough to have lived through the HMO era of the 80s and 90s, which was a failed experiment, I would argue, because the incentives weren't in the right place. And I think that this time we have a better chance of moving things toward a position where we all would like to be, I believe, with better outcomes and controlled cost of care for a couple of reasons. One of the things I wanted to mention to you is about 20 years ago I had the privilege of spending 2 summers in the National Health Service in the United Kingdom. And although it was certainly not a system I would want to adopt from the standpoint that I didn't think a government-run system was one that was particularly efficient or that would work in the U.S. at all, the one thing that really impressed me about the National Health Service was how coordinated everything was in healthcare. Now, you could say, well, that's easy. If one entity is running everything, of course it's coordinated. But it really made me focus on the fact that our system is about as disjointed as it could possibly be. We have technology that doesn't talk to one another. We have providers that don't talk to one another and have no incentive to do it. And we've evolved a system that really doesn't reward the outcome of whatever is happening to the patient in the healthcare system, much less get the patient involved in their own decision-making. So I will start off this program, and we'll see how many people agree with me or want to argue with me. That's the good thing about being first. I am very optimistic about where we're going. Now, I am not blindly optimistic, because I certainly recognize that there are enormous obstacles from going from where we have been, basically since post-World War II, and even more recently since Medicare and Medicaid were created in 1965, which is now an eternity ago, to where we want to be. But I think there are a number of things happening that really make it possible to happen within a relatively few number of years. I think there's a couple of things that we should feel good about. One is you hear a lot of conversation about a focus on both cost but coupled with value. In the HMO days, the focus was really on how do we control cost and how do we use what was referred to as a gatekeeper model for patients in order to control the cost. You never heard anybody talk about value at that point. What are we really getting for the dollars that we're spending? Because I think most of us as citizens, as employees, as employers, are willing to spend a fair amount on health care as long as we have value associated with it. Second thing I would argue is this system really looks at what the patient needs, not necessarily what the patient wants. And if you think about, I mean, I'm not a medical person, so I can say it as a lay patient. We're greatly influenced by a lot of things, aren't we? Television advertisement for prescription drugs, what we read on the internet. You know, every time anybody in my family has anything happen to them, I immediately Google it, and then I have trouble sometimes sorting out what's good information from bad information. But we have an awful lot of information that generates expectations of us as patients. But this new reform system, I think, is designed more to focus on needs. The best thing I think about it is it's really creating different alignments among all kinds of providers. Physician providers, healthcare systems, home health agencies, other kinds of providers, nursing homes. I think you're going to see coordination that you have never seen in your entire lifetime in the U.S. healthcare system. Now, do we go from 0 to 60 in 10 minutes? Absolutely not. It'll evolve. But the incentives are being lined up so that various providers are really incentivized to speak to one another, to work together, and to think about what's the common goal for the patient rather than separate goals all across the various systems. I do think that there is going to be more standardization, and for those of you who are clinicians, that does not mean cookbook medicine, that horrible phrase, but I mean, I do know enough as a layperson from a lot of things that I've read that there is enormous variation in the way that the identical disease or injury is treated in the United States. And I'm not saying that there shouldn't be some variation, but perhaps the enormity of the variation is not necessarily producing the best outcomes at the best possible cost. Two other things. One is technology. I think that's the single biggest driver in terms of being able to get us where we're going, and part of the reason that the HMO era failed, in my opinion. Right now, we are much more evolved in terms of electronic medical records and having various providers across many, many systems be able to look at our information virtually in real time, not repeat tests, not understand what medications we're on, but really have the big picture. And that's an enormous step forward in terms of being able to achieve the kind of coordination that I just mentioned. And then finally, I think that there's a lot more transparency now. Healthcare is kind of a mystery, isn't it? I mean, many of us grew up as employees understanding that our employer, or if we're on Medicare, somebody else is paying for our health care. We don't really know how much it costs. We just show up at the various providers and know that somebody else is going to be responsible for the bill. And we don't even really know whether we can make informed choices because we don't have the information. That's definitely changing. A lot of employers have moved toward high deductible plans or plans where individuals are really incentivized to pay attention to how much things cost and make some judgment about whether they choose a particular provider or whether they choose a particular pharmaceutical or something else because they are incentivized to pay attention to the cost, which we never have been before. So I think that the reason I'm optimistic is because I think we have to address the issue of the 47 or 9 or whatever the number is million uninsured in this country. Do not think for a minute that those individuals are not getting care. They are getting care. They're just getting it too late and in the most expensive places. So that's not really a very good, effective healthcare system. They're getting what they need eventually, but not in a timely way and costing an awful lot of money. So if we can cause all of those individuals or a great number of those individuals to have some form of insurance that will get them into the system at the appropriate time, I think that you'll see a major cost impact there. I think that you're starting to see more employed physicians, but I think you'll continue to see an enormous number of independent physicians. And I think there's a very important role for independent physicians who are in their own practices. But they're going to be coordinated, and the regulations and the antitrust laws, as an example, are going to relax in order to let them coordinate and cooperate with other providers who may have been thought of as competitors before. I do think you're going to see a big blurred line between what happens to patients when they leave the hospital, and I'm sure John is going to mention this a little bit too. Right now, patients can go anywhere from a rehab hospital to a long-term care facility to a long-term care hospital, home to the home health agency. I mean, there's an enormous menu, and yet it's very difficult sometimes, I think, for the patient or their families to choose. I think you're going to see blurred lines in terms of the location of the delivery and more emphasis on what happens to the patient when they get there. And finally, I think that, and you're seeing this already a little bit, there's going to be much more combination, whether it's in joint ventures or actual combinations of health systems and insurance companies, because that's ultimately where the focus on incentives lies in terms of spending the appropriate amount of dollars and getting the right amount of outcomes. So I'm optimistic about where we're going, and I recognize that it's going to have enormous hurdles to get there, but I think we should feel encouraged.
Thank you. Thank you. And did Dr. Opplinger, is he here this evening? Is Dr. Opplinger? There he is. Carl, I just have to acknowledge my zoology professor from 1977, Dr. Carl Opplinger, who's here this evening. And we've stayed friends all this time. And I tell this story, I just have to tell it again. He's heard it a million times. And so we're in zoology class, and there's like 200 pre-meds. And we're talking about mammals. And one of the things that distinguishes humans from other mammals is the ability to laugh, or at least it was believed. So I raised my hand and I said, you know, Dr. Opplinger, I don't think that's really correct. It's pretty bold for pre-med. He says, what do you mean, Mr. Singer? I said, well, I think the rest of the animals just don't get the jokes. But it is my, oh, and by the way, the food is out. If you're hungry, you want dessert, extras, please get up and get additional food. John KRISTEL is the new president and CEO of Good Shepherd. And when I mean new, I mean, I saw in the paper it was technically just installed last week. Last week. That's pretty new. Prior to becoming the CEO of Good Shepherd Rehabilitation Network, he was the chief executive officer of the Carlisle Regional Medical Center. And previous to that, he served as the CEO of Berwick Hospital and associate CEO of Pottstown Memorial Hospital. He actually began his career as a physical therapist. He graduated from Temple University with his bachelor's degree, got a master's degree at Drexel, and then he got his MBA at Temple University Fox School of Business. But the most important thing he did, the smartest thing he did, was soon after becoming the CEO at Good Shepherd, he moved in directly across the street from Bonnie and me and the girls. His wife, Monet, and his children, Max, Alex, and Anna, have quickly become our friends and my children's friends, so it really is very special. So, John, thank you. I know it's been very hectic for you getting settled, but thank you for coming, and we look forward to hearing your talk.
Thank you, Ray. I was thrilled when I received the invitation tonight, not just to get a chance to introduce myself to Muhlenberg and get a chance to meet a lot of great people here, but when I saw the topic, I thought to myself, I always wanted to be a weatherman and know what it felt like to not really worry about what my predictions were going to be. If they were going to, I have a 50-50 shot here, because as was already mentioned, a lot is going to change, even maybe by tomorrow. So it's a tricky topic, healthcare reform, to talk about. So what I'm going to do is focus a little bit on Good Shepherd and what we do as a post-acute care provider, what we focus on. And it's interesting because I look at healthcare reform and I hear a lot, you heard JOANNE mention it, a value proposition. And it's an interesting couple of words thrown together. They're almost buzzwords now. If I were to transition my career and become a consultant, if I led with that line, I think I would get the job. It's things people throw around, but value is different to every single person that touches the healthcare system. So in post-acute care, we have to know who are our customers truly. And it's people that are utilizing us, not just in terms of patients, but also the health systems that are sending their patients to us. And what Good Shepherd recognized it needed to do, what we did when healthcare reform was first being talked about, we tuned in to what it meant for our acute care providers, the folks that are sending us a lot of our patients. And we noted, we started to see things like they were going to be penalized if a patient was readmitted to their hospital within 30 days. And what that said to us is we better pay attention to this. We better provide their patients that they're giving to us now and entrusting to us with such good service and such high medical quality of care that we minimize the number of times a patient will have to be readmitted within 30 days. Because the consequence to the acute care hospital is severe. They won't get paid for that readmission within 30 days on certain Medicare patients. And that's a rather blunt hammer to hit in order to try to reduce healthcare costs. I won't steal Ron's thunder later if this is part of his presentation, but it's not exactly a precise way to cut healthcare costs for lots of reasons. Nonetheless, it's important to us at Good Shepherd that we say, how can we be a good partner? We've always cared about providing a high level of quality to our patients and helping inspire hope within them to return to their best functionality that they can and recognize their best potential. But now we also have to pay attention to how are we impacting the folks that are sending us their patients? What is our value? And if we're readmitting a lot of the patients that they send to us, that's not going to be seen as very valuable. So that's one of the ways that healthcare reform has already driven a change for Good Shepherd. Another thing is it's forced us to look at, and this one's hard for me because as a physical therapist, I was always trained that we're part of the solution in healthcare. It's more efficacious, it's more cost-effective to have a patient try a conservative course of physical therapy and potentially be successful than have to need outpatient surgery or even an inpatient surgical procedure. So that to me, I say to myself, hey, that's pretty valuable. However, there have been multiple hurdles during the managed care era that have been placed in the patient's way to get to us in order for patients to receive care. And in many ways, I understand why those hurdles were there. They were a check so that there wouldn't be this unconstrained utilization of physical therapy, which, by the way, I think is kind of funny because most people that have gone through physical therapy aren't exactly dying to get there to see us as physical therapists, right? They're a lot of times talking about their experience and they're calling us physical torture instead of physical therapy. But with that being said, we recognize that we bring a certain value in terms of the potential to save on more costly interventions. Not always. We're not going to save every low back pain patient from needing surgery, but we know that there has to be checks and balances in a system. And for a while, the checks and balances were that a physician would need to order physical therapy. And an insurance company many times would have to provide an authorization for that patient to receive physical therapy. And we learned to work within the constraints, if you will, of this system, and it seemed to be working fairly well. However, as we all know, and as JOANNE aptly pointed out, our spending on healthcare continued to increase, and the therapy world needed to share on the I don't know, you were able to make it sound optimistic, Joanne. I wanted to call it pain, but we had to share in some of the pain with this. And there were certain things put on, like therapy caps, so that patients weren't able to spend, Medicare patients aren't able to receive more than about $3,000 worth of care for PT in a year. So we've adjusted to that as well, and have made sure that we're very cognizant of the cap. But I have to say, one of the most profound impacts I've seen, both in my experience on the acute care side and the post-acute care side, is most recently, it's just been like a storm. And Joanne, you almost did my presentation for me here. I apologize for the redundancy, but these high deductible plans are probably really the first thing in my career that I've seen that have significantly altered utilization. And unlike Joanne, I'm not sure yet if it's always a good thing. I think it is good for patients to have an awareness of, you know, how much things cost and why things cost differently for different levels and different organizations. However, I do also fear that while patients may choose lower cost settings for themselves once they know they're on the hook for the first $1,000 of their healthcare spend each year, they may also put off important things. Luckily, I believe that our insurance company partners have recognized that and have started to say, okay, well, you'll have caps for certain things here, and other things here that we consider preventative won't be capped. But there's still, I think, a tendency for patients right now to be very price sensitive when that first large chunk of dollars is coming out of their pocket, for them to sit there and say, you know what, I may just put off this service that I need. And that, unfortunately, could be the law of unintended consequences, where medical care is put off for someone, and then they end up landing in a hospital ER. And once again, that we all know that can be a very high-cost area for patients to receive care. So that is a concern of mine. And I'd finished my statement with one other thing. One thing I'd really like to see is more dialogue with the physicians. When I speak with physicians one-to-one about what do they think are some things that could fix healthcare, they're not going to tell you, usually they don't say to me, EMR systems. I haven't met a physician or a therapist yet that has told me that an EMR system has made them more efficient in treating patients. There are good things about them, and we recognize that's the way it's going to go. However, it sure would be nice to take the noose of trial lawyers and how hard they go after doctors if they miss a diagnosis, or if they don't do a CT scan, for example. As a patient comes into the ER, our physicians are forced to practice in such a way where they eliminate all possibilities of something being wrong with a patient, because if they don't do that, and that 1% case does happen, it can lead to a multi-million-dollar settlement. And just as importantly, it can really damage the psyche of the physician, even though they know that that could happen and there was a chance that that would happen. When you talk to physicians that have been through that type of malpractice trial, it's just a nasty experience that I just think it needs to be fixed. I think it would be a gesture where physicians would truly engage in how to take costs out of the healthcare system. Just to take that noose off their neck to say to them, okay, if you don't have to worry about no caps on pain and suffering, then how would you practice in the ER? How would you practice in primary care? What tests and studies would you recommend? And I think you would get a health system fixed from within, as opposed to one that's being legislated with unintended consequences. Thank you so much. I appreciate your time.
Well, it's going to be an exciting panel discussion. A couple of well-known and very dear friends of mine, attorneys Phil Hopp and Candy Heimbach, are here this evening. So I'm glad John brought that discussion up. And also, just this past week, I had a patient who was putting off aortic valve surgery because his deductible is too high and he's worried about his job. So this is real stuff. This is real-life stuff that's going on. And our next guest speaker is Christopher Molyneux. Chris is the president and CEO of Pennsylvania Bio. Now, you may not have heard of Pennsylvania Bio, but it's a very, very important organization. They are the chief representative, spokespeople, and basically advocacy group for all of Pennsylvania's biotech, device, diagnostic, pharmaceutical, and research organizations. Now, prior to joining Pennsylvania Bio, he served as the worldwide VP for Pharmaceutical Communication and Public Affairs for Johnson & Johnson. Prior to that, he was the VP of Communications and Marketing at Blue Cross and Blue Shield Association. And among other positions, he worked as a public affairs executive for the Federal Departments of Health and Human Services, and he served on the White House staff of President George H.W. Bush. So it really is an honor to have you here this evening, Chris.
Well, thank you, Dr. Singer and President Helm, for pulling together this panel. I appreciated John's comment about being a weatherman and not being able to, not having to worry about how things really turn out tomorrow. You know, I think that this is obviously an important and very timely topic, and you pulled together a great set of representatives from different sectors of the industry, different sectors of the healthcare community. And it reflects the interdependencies that are really inherent in where healthcare is going in the future. What's interesting, though, not on the panel, is representation from the healthcare IT community, which actually really is going to form the underpinning of healthcare as we go forward. And hopefully that's because they're all in Washington trying to straighten out the website. But it really is important to recognize, and I think JOANNE touched on this, the interdependence that maybe it's being forced, but the alignment that needs to happen among the different sectors of healthcare, industry, academic research, the payer community certainly. We're all in this together, whether we like it or not. Now there's no room for silos, really. We do have to work on this together. JOANNE and John actually touched on a lot of what I wanted to cover. So I thought I'd maybe take it up a couple thousand feet, as well as go a little into some detail with some numbers to expand on what they each said. Healthcare reform, from our perspective as the representatives of the industry side of the equation, really for us is all about access and affordability. It really was mostly about insurance reform and ensuring that patients have access to treatment, bringing down that number of uninsured, and addressing a painful need across the country for folks to have good quality, value health care, as well as ultimately good outcomes as a result of that health care. But I want to just throw a couple numbers at you because this is all boiling down to cost. It all is designed to make affordable the healthcare system that we've all become so accustomed to and are privileged to have in the United States. When you look at the $3 trillion number that JOANNE put out there, she mentioned that that's larger than the budgets of many countries. In fact, that makes our healthcare system, combined with Social Security, the 5th largest budget in the world, behind the United States budget overall, China, Japan, and Germany, and then the American healthcare system. So that is a tremendous burden. It's also a tremendous responsibility for the folks represented at this table, the industry sectors and the healthcare system represented at this table, to do it effectively with ultimately the most beneficial outcomes. So what's driving those costs? And if we look at the future trends in costs and sort of where we've come from, if you look back to 1965, the combination of Social Security, Medicare, Medicaid, FDA spending, CDC, Centers for Disease Control and Prevention, National Institutes of Health, it combined for less than 5% of the GDP of the United States. By 2010, that it combined for over 10%. By 2030, it'll hit 25% at this rate, and by 2040, it'll near 30% of GDP. Obviously not sustainable, but driven by some really good quandaries, I guess. You've got people living longer because of advanced healthcare technology, because of different treatment options, because of the therapeutic industry and device industry that I represent. So folks are living longer, healthier lives, but that's expensive. So we have to figure out how to manage that while also managing costs. So there are currently 72 baby boomers in the United States. 10,000 people per day turn 65. And as they retire, obviously they're eligible for Medicare. People are living longer than ever before, and it's largely because chronic diseases or diseases that have been characterized as chronic diseases are being managed much more effectively these days. Cancer, for example. In 2010, the country spent about $125 billion treating cancer. By 2020, that's expected to be $207 billion, so about a 66% increase on treating cancer. Alzheimer's disease in 2010 was about $172 billion. By 2020, that's expected to be $241 billion. Diabetes, 158% increase from 2010 to 2020, from about $194 billion to $500 billion a year spent on diabetes anticipated in 2020. And then heart disease, 2010, $272 billion spent, and by 2020, it's expected to expand to $473 billion. So an aging population, a healthier population later into life is part of the challenge. And that's how I think that the country and the folks trying to solve this problem need to look at it. These looming costs, the expansion of spending on gross domestic product in Medicare, Medicaid, funding for the FDA, for the CDC, Social Security, those aren't the issues. Those aren't the issues we should be tackling. The issues we should be tackling are these diseases, the diseases that are really inflating the spend each year, and look at ways that those costs can be driven down in the most efficient, most effective way. So it is, as Joanne said, and I think you'll probably hear a couple of times tonight, it is all about driving value and outcomes in the most efficient way. So let me turn for a second to to some of the issues or some of the items, provision of the Obamacare bill that's rolling along. First, the importance of protecting innovation. And there are provisions in the Affordable Care Act that do, in fact, protect innovation. The innovation that Joanne touched on, the importance of protecting intellectual property, also allowing innovators continue to do what they do best. What you heard from Dr. Singer earlier about Muhlenberg, what he did down at Penn. Penn is one of the top 5 in the country in terms of NIH funding, second only to Johns Hopkins. University of Pittsburgh is number 5. So we've got 2 of the top 5 NIH-funded universities in the country right here in Pennsylvania. And that's because they recognize, the NIH recognizes the innovation, the potential for commercialization of technologies out of those universities to help patients and ultimately drive down costs. But in the Affordable Care Act, there's what's called the Independent Payment Advisory Board. And some of you may have heard that acronym, IPAB. That's of great concern. The Independent Payment Advisory Board is a presidential appointed group of folks, not elected officials, 15 people who are tasked with driving down costs. They don't have to have medical degrees. They don't have to have a healthcare background. Their task is to drive down costs and ultimately make decisions about what should be reimbursed and for how long. That's a big concern. Statutorily, they are tasked with driving down costs, not necessarily driving value. Another provision of the Obamacare bill is the medical device tax. And this is something that has hit home here in Pennsylvania very heavily. This is a 2.3% excise tax on medical device companies for the products that they sell. What's important about that issue is this is a tax on invoices. So this is a tax on every medical device company. As they sell their products, they've got to pay a 2.3% tax to the government, whether they've been paid or not, whether they've had the receivable in or not. To this point, that took effect in the beginning of this year. To this point, the medical device tax, the medical device industry has already paid over $2 billion into the federal government to help fund Obamacare. That's a big concern. The reason it's a big concern is that affects all medical device companies, even those who have not yet reached a profit. It generally takes about $50 million in revenue for a medical device company to start to see a profitable return. So those companies who are still in startup mode, many of whom, most of whom, about 80% of whom are still losing money as they develop their products, are now paying a 2.3% tax to the government. That leads to job reductions. That leads to reductions in investment in research and development. And really, it's a job killer and something that we are really working hard to have repealed. And I guess the last thing, just in the interest of time, that I'll touch on with respect to the Affordable Care Act is the notion that by enrolling more patients who currently were uninsured, enrolling them in insurance and providing access to health care, that somehow the pharmaceutical industry and the medical device industry will have a windfall of patients is just patently incorrect. Government knows how to control costs two ways, either price controls or reducing access. And that's what's going to happen to the American healthcare system as CMS, who manages Medicare and Medicaid, and the Independent Payment Advisory Board need to control those costs. So that's going to result in a reduction of reimbursement to physicians, reimbursement to the innovator industry that I represent, and ultimately could be a job killer and certainly retard innovation moving forward. So I guess the last piece, and Dr. Singer, you asked us to touch on the role of the region here. I think the most important role, and I know I sound sort of doom and gloom, but the most important role for the region, for Muhlenberg, for the academic research community, is to continue to drive innovation, because innovation is ultimately what the payer community is going to be looking for. They're going to be looking for value. The provider community is looking for more efficient ways to deliver medicine, to deliver treatment. So the academic community and this region is rich in medical device and diagnostics companies in particular, but also in pharma and biotech. Driving innovation, coming up with those solutions is what we do best as a country, and as you mentioned earlier, this is a hub for that. So thank you for your time, appreciate it, and look forward to the conversation.
That's going to be a very important part of the panel discussion because, and of course we know that innovation is expensive too. And not every new innovation works, and then what do you do with that? So a lot of good substrate to talk about during the panel discussion. Gary St. Hilaire is the president and CEO of Capital Blue Cross. Prior to becoming the CEO, he was their executive vice president and CFO. And before joining Capital Blue Cross, he co-founded and was the CFO of a healthcare technology company known as ChoiceLinks. That company later got bought by Cigna and remains this day a very active, successful part of that larger company. Prior to founding ChoiceLinks, he was the executive vice president and CFO at Blue Cross and Blue Shield of Massachusetts, and a graduate of Southern New Hampshire University. Correct? Good. Thank you, Gary St. Hilaire, for coming here. Can I get my insurance policy back? No, I'm just kidding.
Maybe. Yeah. How many people saw the press conference today with the president or heard about it? Okay, so you all know who's going to fix the promise, right? We are. We have some interesting things coming down the pike. I do want to thank you for the opportunity tonight and to join these fine folks. The perspective on healthcare healthcare reform is very interesting. From a health plan perspective, it's not all that different from what you're hearing up here. I'm not sure that healthcare reform itself as a law, is doing much other than providing that access. And I think as we're all experiencing, there is a lot of confusion. And one of the reasons for that confusion is it's much more complicated than anybody would really like to think. It'll actually make your head hurt when you start thinking about the various ramifications, downstream implications of a lot of the changes in the regulations that have come out. We were overwhelmed by the size of the health care law. You know, the proverbial you have to pass it before you can know what's in it. I think that was actually a true statement because it took that long to read. But the follow-up regulations that have since come out are just, there's volumes of them. And they're still coming out. Even for things that were already in effect. So it gives you a sense of what we're dealing with. And as things happen, so as what happened today, where the president announced that he was going to try to come up with a fix and he was going to look to the states, but authorize that people, if they wanted to keep their plan, could do so. There are lots of ramifications to that, especially given that a lot of insurers have sunset those plans as required by the health care law, and don't have plans to be administering to them. So they've made changes to their systems. They've made changes with their regulators. Those plans are no longer there. So it becomes challenging to say, so how are you going to kind of put the genie back in the bottle, so to speak? Those are some of the complicated issues that we're dealing with. One of the things as we think about healthcare reform, I think there's a lot of opportunity to come out of healthcare reform that isn't part of the legislation. So we talk about access. You've heard about providing access, and that's really, I think, what this was. This was a health insurance reform law. I think that was the right description. And I think it was meant to provide access. It didn't address the cost issues. But you're seeing a lot of that happen because I think that the payers, the providers, the employer groups, and the consumers are realizing that we have to come together to kind of figure this out and come up with solutions not only around payments to providers, but around the benefit designs that are associated with that will incent the proper behavior and the right kinds of I guess acquisition, if you will, of services from providers, thinking about how it is that I get my health care, how do I try to stay healthy, all of those things. And if you think about going back to the managed care, call it a long-term pilot plan back in the 80s and 90s, I got my start in HMOs as well, and I think it was just kind of it was a financial fix. It really wasn't that fix on quality. It wasn't that understanding that payers had to work closely in partnership with providers. It was kind of offloading of risk, and that's one of the reasons it didn't work. But it also didn't pull in employer groups and consumers. How many people here go out and purchase a car without knowing how much it costs or what's in it? Right? You don't. You go out, you do your research, you try to understand what is it that I'm purchasing here, is there value to it, and is this what I need? And getting people to consume healthcare in a way that helps them understand what it is that I'm consuming. And getting employers to put the right kinds of programs. One of the things that we've done at Capital is around value-based benefits and trying to understand, so how is it, and it's not just the preventative, but how is it that we incent? So when someone has a chronic illness, diabetes, how is it that we make sure that when they're doing the right things, when they're getting their screenings, when they're going to the doctor's office, when they're trying to get their supplies, those kinds of things they don't have to pay for? So what kind of programs can we put together with employer groups to make sure that those folks are doing those kinds of things so they don't have the episodes of care as a result of not having taken care of their diabetes? Those are some of the changes that we're seeing happening. And it's important for us, and you heard the term value. It's something that we've actually utilized significantly at Capital, the whole term of medical value. And what is value? Value means a lot of things to a lot of different people. If you were to ask a normal consumer, tell me what medical value is, they probably couldn't quite put it together. So what we've done is we've done a lot of research, working with consumers, working with providers and employer groups to try to piece it together. And we've narrowed it down to it's really kind of three simple things, really. One is quality. Everybody wants quality, and quality is often defined by the outcome of their experience, right? The other is cost. There is a certain element of cost that nobody wants to pay more than they have to for that new car. So there's a certain value associated with doing it at the right cost. And then, of course, satisfaction. What was my experience from everything from getting the care that I sought to the fact that the claim was paid in a certain way that I don't have to really kind of fight the issue. So when you put all those pieces together, in essence, that describes value. Well, those three elements require that all of us in the system are working together. Health plans, consumers, providers, and employer groups. That's the only way that you get to that value proposition, is when everybody is working together in that way. And the challenges, I think, of the healthcare reform law, as we think about the implications on our business, and our business is everybody's business when you're consuming and purchasing your health insurance, is there are a lot of complexity. So take, for example, the fact that you've seen a lot and late about the cancellation notices that went out that ended up with the President speaking today on that. Those cancellation notices went out because, in large part, they were required to go out. We had health plans that didn't have what was defined as essential health benefits. What are some of those essential health benefits? Well, what about pediatric dental care? So how many folks in this room, given where you might be in your current lives, feel that it's essential that you have pediatric dental care in your health plan, right? There's a lot of folks in this room that say, that's not something I really need to have. Well, if you didn't have it and you had an individual plan, your plan had to be canceled so that we could send out a new plan that had that benefit in it. Those are some of the challenges that we face. So as those cancellation notices went out, we knew what those implications were. We were on all sorts of panel discussions. We have a whole team of dedicated folks that are living, eating, breathing healthcare reform that work through all of these things, working with folks at CMS to really try to educate the administration and all of the folks that are working on this and these kinds of things. But at the end of the day, the reality is we ended up with what it is that we had, and as a result, there were implications. What are some of the other implications? Well, there is an excise tax that's going to go, that's going to be assessed to all insurance plans. For Capital Blue Cross, just here in central Pennsylvania, depending on the year, because it's going to escalate, is going to range anywhere from about $30 to $45 million a year. Now, that's not something that we can afford to absorb. It just isn't. We run a very, very razor-thin operating margin, typically in the 0 to 2% range if we're having a good year in that regard. So that might spin off $10 to $20 million of operating revenue in any given year. Well, a $30 or $40 million bill can't really come out of that, so it's got to come out of premium. Well, the one other add on that is it's not tax deductible. So you have to gross it up in order to make sure that at the end of the day, you know, your bottom line hasn't been affected. Well, why is that bottom line important? One of the main things that the insurance department wants to make sure is that we're still here to pay the claims and that we're solvent. So we have all of these downstream implications, and it sounds wonderful to make sure that we're funding all of these issues, but at the end of the day, that comes out of the premium. And when it comes out of the premium, it comes out of people's pockets, whether it's the employer groups that are paying a large share of it or the individual consumer that has to bear that burden. When you consider some of the other mandates that get put in and the fact that we have to cover a larger pool of folks that need coverage. There's a pent-up demand for people that haven't had insurance to get coverage, and those people ought to have access to that care. But there's a cost to it. And as long as we understand that cost, then at least we can kind of enter into it. But I think that there was a large misunderstanding about what that cost was. So those are some of the challenges that we faced, and how do we do that? And how do we do that in the context of who we are? I have to say, I've been in healthcare most of my career, a little over 25 years, and in all of that time, I've worked in publicly traded companies, privately held, not-for-profit, and I'm very, very proud of who we are at Capital and who we are in this region in central Pennsylvania and the Lehigh Valley. And if you think about this area, and I moved here from New England, and moved here with my 6 kids, and our experience, our whole life had been kind of that New England, Boston, New Hampshire markets. And one of the things I have found is that this region is a wonderful, wonderful family-oriented region. We've been here now for 8 years and have absolutely loved it. And one of the things that I get a sense of, and I got a sense of really my first year even working at Capital, but in dealing with a lot of employer groups, is how people take pride in their community and what they mean to that community. And I look at the time at Capital Blue Cross as a nonprofit local health plan, takes a lot of pride in what it is to the community and its responsibility to the community. We've been able to stay local. We have focused all of our energy on not only working with providers and employer groups in this organization, but community groups. So for these things for us, as we think about how do we factor in those costs into premiums, it takes a lot because we feel the impact. You know, as we turn around and deliver those, no one wants to deliver a premium notice that's got a 10% increase, never mind a 5% increase, because that increase is going to my neighbor. That's going to a friend down the street or a colleague across the city. So it's important for us to make sure that we not only get this right, but do it in a responsible way. So I think there's a lot of great things that are going to come out as a result of reform. I don't think as a result necessarily of the legislation, but I think because of the drive and the innovation of the folks that are in this room, at this table, and in the community to make sure that we have a good health system. Thank you. I look forward to the questions.
I asked him if the excise tax was the Cadillac tax. That's yet another tax, and well, maybe it'll go the way of the Etzel. Before we introduce the last speaker, I would like to introduce what I think are the most important people in the room. How about our college students stand up and take an applause here? My kids, our kids. I know, thank you very much. And I know that it's midterms, and I'm available to stay afterwards. There was a plan to get some coffee and some beer, and we'll talk about pre-med. And a lot of these questions will be asked during your interviews. And the good news, what you're learning today, is you can say anything and you'll be right. So, so that's the great thing about this topic for your interviews. Dr. Ron Swinford is the president and CEO of Lehigh Valley Health Network. Prior to becoming the CEO, he was the Chief Medical Officer, and I must say, also honored tonight to have our current Chief Medical Officer, Dr. Tom Whalen, is here this evening as well. Dr. Swinford came to us from the University of Missouri-Columbia, where he was the chair of the Department of Dermatology, as well as the Chief of Dermatology for the Harry S. Truman VA Medical Center. Prior to this, he was the chair of the Department of Internal Medicine, Chief Medical Director of Ambulatory Services at the University of Missouri Health System. He was also the Medical Director for Missouri's Telemedicine Network and Medical Director of the Network Development at the University of Missouri. Dr. Swinford served in Vietnam in the United States Army, and I think that, and to all of our some of our soldiers and veterans and families of veterans who are here this evening. In fact, Dr. Whalen, who's Navy, and here this evening, also honored to have Rabbi Seth Phillips, who was the Navy chaplain for many, many years. He's the rabbi at Congregation Knefes Israel, which almost basically shares this campus where my family and I are congregants. And also my mom, who served as a Navy nurse during World War II. So thank you for your service always. It's one of the things I was always a little bit remiss that I never served, but I've been told that it's probably a good idea because likely I would have been shot by my fellow soldiers, so it's probably good that I never served. Now, Dr. Swinford went to medical school at the University of Missouri-Columbia and is board certified in dermatology. His internal medicine training was at the University of Virginia, and then he returned to the University of Missouri-Columbia for his dermatology training. But here's the most important thing to know about Dr. Swinford is his emphasis on developing future leaders, and it's really reflected in the keynote thing that he's done to assist Lehigh Valley Health Network to become part of the University of South Florida, a very special program called the SELECT program. And maybe some of our students will apply to this program. And this program is specifically to make not only better doctors, but healthcare leaders tomorrow based on emotional intelligence, communication skills, and very patient-centric, putting the patient first, which may seem obvious, but has not always been the case through the history of medicine. And I think this is just a wonderful program that I'm proud to say that at Lehigh Valley Health Network, we're a part of it thanks to Dr. Swinford. Ron?
First, a clarification for those college students. Those blurred lines that Joanne was referring to is not the blurred lines you were thinking about. Because of what you've already heard, I'm going to put a quick frame around the big part of healthcare and then get right to what we're doing as providers to respond to that. First of all, in the spirit of Christmas, I believe we do need to reform healthcare in this country. There's little question about that. You've heard the numbers. By 2020, they estimate that 20% of our gross domestic product will be consumed by healthcare. Something needed to be done, and the Patient Protection Affordable Care Act is just the latest experiment, if you will, to try to address that need. We've been through HMOs, we've been through capitation, we've been through managed care, which, as you heard, was more managed cost than it was care. And so now we're going to try something new and different. So Congress passes this law, which I only learned a year ago, was the rough draft of the law that was hurried up because of some special elections that were going to occur, and they're afraid they wouldn't have that extra one vote. And so the rough draft that was passed resulted in exactly what I feared. And that was, okay, we'll try another experiment to manage costs in this country. But what I worried about is exactly what happened today, what happened about 3 months ago whenever they postponed the employer mandate, and so forth. It's the recalibrations and the shifts that are occurring that make our lives so difficult because every time they click and make a change in that, we have to click and change ourselves because we have to respond to that. And that's the difficult part of this. The Institute of Medicine estimates that 30% of the dollars spent on health care does not add value. Well, I think we have some opportunity there. At Lehigh Valley Health Network, for the last 5 years, we've removed $40 to $50 million from our expense side. That's hard work, I can assure you. We're talking of $250 million over the last 5 years. It's what needs to be done. And so I don't focus so much on the Affordable Care Act as I do on what the Institute for Healthcare Improvement calls the triple aim. And you've heard it referred to here. Gary made reference to it himself, not calling it by name, but the triple aim that the IHI postulated is, what do we need to do to reform healthcare in the United States? You've heard it already, and you all could write it down. We need to reduce the cost, we need to raise the quality, and we need to engage the patient, what is now sort of pejoratively called population health. Make us healthier. Nobody gets engaged in a conversation about healthcare reform that someone eventually doesn't say, doesn't the patient have some responsibility for their own health care to keep themselves healthy, don't smoke, ideal body weight, don't drink too much, and so forth, exercise? That's the population health piece that we are beginning to get responsibility for as providers, as well as the payers having responsibility for that too. So what are we doing at Lehigh Valley Health Network? We're trying to respond to that triple aim, and as I described it to our Chief Strategy Officer in January of 2012, almost 2 years ago, I said, we're just going to leapfrog this Affordable Care Act and do the right thing to address the triple aim. Reduce our expenses, keep pushing on quality. We've received a lot of awards and recognition for quality in our network, and begin to engage the patients in care. One of the big movers in all of this is to try to prevent patients from getting admitted to the most expensive venue for health care delivery, the hospital. And to keep people out of the hospital, we have to address them and keep them healthy and help them manage their own care. So toward that aim, recently, just 3 nights ago, I was reading that if we could get patients with chronic conditions, and again, you heard a comment made about managing chronic disease, if we could get patients to manage their chronic conditions and just take their medicines, we would reduce $300 billion in expense in this country. Just 3 diagnoses: patients with high cholesterol, diabetes, and hypertension. If we could just get people to regularly take their medicines, it's $100 billion of that $300 billion. So we know there's opportunity. We know it's there. So we are trying to get closer to the patients, take care of them closer to their homes. We're building health centers around the valley. We'll open a walk-in clinic in Bangor Monday with 3 providers there, and they're there from 8 in the morning till 8 at night, and they're there on Saturday and Sunday also. Access. The one thing that people believe is about quality is access to their providers. Don't you get frustrated when you call your doctor's office and say, gee, I've had this cough for about 2 or 3 weeks, and I'm worried I've got a bronchitis or maybe a developing pneumonia, and I might need an antibiotic. Can I come in? And they say, how about a week from Friday? And you say, maybe you misunderstood me. I said I've had this 2 to 3 weeks, and I need help now. So we have opened 6 walk-in clinics, with the 7th one opening Monday. And from January of 2011 until July of this year, 35,000 people walked into those 6 locations. Of those 35,000 people that walked in for their care, 8,500 had never seen our network before. It's a business strategy as well as the right thing to do. So another example of what we're doing. Managing chronic disease, we've developed what we call community care teams. These are teams assigned to some of our primary care offices, and they're doing that chronic disease management. What we learned when we looked at the patients that are our employees, 12,000 employees, when we looked at our own claims data, we spend $123 million a year to provide health care for our employees and their dependents. When we looked at those with chronic disease, we found that it was often complicated by behavioral health or mental health problems. And you can see the vicious cycle there. If suddenly you have disfiguring arthritis, you can no longer function, you can't work, you can't even do the things recreationally you used to do. It's a little depressing, and that begins to start the snowball and the vicious cycle of complications. If you have manic depressive disease, you may not be too good at managing your diabetes. And so one of those providers in the community care teams is a behavioral health specialist to help those patients learn how to manage their own diseases. So lots of initiatives within our network, and some other things we're doing is telehealth. I've been involved with telehealth for 20 years, and it does work. We manage Parkinson's disease patients just near here at the Phoebe, so that they never have to leave the home to get their Parkinson's care. Dr. Peter Barber of our neurology department sees them through a video connection, and how wonderful the families appreciate not having to bundle up their mother or their dad and haul them across town, have them sit in the waiting room for 20 minutes or an hour, then be seen, wait for that. These people are losing a day's work just to bring them over. Telehealth. We have telehealth being broadcast to Beth Township, to Hamburg, around our network. This will help reduce costs. It will raise quality because people will get care earlier. When a psychiatrist can see you in Hamburg today just by a flip of a switch, that's quality care. Another thing that we're doing is, while we employ over 600 physicians, now there's a hell of a payroll, right? We employ over 600 physicians. We also employ over 300 what we call advanced practice clinicians, nurse practitioners, physician assistants, some of them here tonight. And these individuals work in concert and as part of the team to provide care, and it helps spread our ability to provide care at a lower cost. They work as teams. The SELECT program with the University of South Florida that Dr. Singer referred to is trying to train physicians to be better team players rather than feeling like we are the know-all, be-all, end-all, and know everything, because we don't. And so we need a team, and so we've expanded a lot of our advanced practice clinicians. And finally, partnerships are very important to us, and we are looking for the right partners. Some of those are on the panel tonight. Capital Blue Cross is a great partner to us. Pediatric dental care, we in partnership with Capital Blue Cross have a dental van that goes around to the elementary schools and doesn't just provide dental care for these children, puts sealants on their teeth in the 2nd and 3rd grade to prevent them from getting cavities, because if you're in one of the downtown Allentown elementary schools, your future may not be as bright as you might like it, and it doesn't help if your teeth are rotten. So with Capital Blue Cross, we do that, and they have been good partners in many other ways with us. So what we're having to do is not just provide the right service, but provide the service right. And we increasingly will be compensated in that way. Right now, Medicare has developed a new patient satisfaction survey. It has eight elements to it, and Medicare is withholding 1% of our reimbursement for our Medicare patients that we treat, unless we meet all 8 of those criteria set by their standards. Next year, that'll be 1.25%. Following year, 1.5%, up to 2% of the millions of dollars we receive from Medicare for the care we provide to the elderly. Up to 2% by 2016 will be withheld unless we provide the quality care. And many of the payers have quality initiatives that reimburse us if we provide the care at the highest quality and set a benchmark that we exceed. And last year, I'm happy to say, we hit all those benchmarks and received from one payer over $6 million in additional compensation simply by providing the care right at that time. It's an exciting time in healthcare. I embrace JOANNE's comment about optimism. We recently formed a consortium of 6 other health systems of comparable size to our own, over 10 billion gross revenues. We're 1.6, over 10 billion gross revenues, because we believe in those partnerships we can learn the new competencies that are necessary to provide health care at a less costly price, at a higher quality, and engaging the patients. So we will work with those partners to accomplish those things and use the intellectual assets of each of us to do that. Thanks for your attention and time. I appreciate that.
Thank you. And how about a round of applause for all the panel speakers tonight? Yeah, I really do believe that the cup is half full, not half empty, and a lot of exciting things. And so many people here to acknowledge. Obviously, you can't acknowledge all, but Ron mentioned that dental van, and we have here tonight Dr. Sophia Claudius, who was the first woman chair of any department at Lehigh Valley Health Network. She was the chair of dental medicine, and she was instrumental in bringing that to our community. Dr. Claudius is here this evening. Thank you, Sophia. And the first question that I'm going to ask as part of the panel, then we have microphones. Our staff is around, I believe, right? Good. With microphones. It was a perfect segue, because you mentioned that we have 600 employed physicians, another 300 APCs, and here this evening is Dr. Michael Rossi, who is the CEO and the executive of that large group. It has to be, Mike, I guess, one of the largest groups in Pennsylvania, if not the largest group in Pennsylvania. I believe our budget is probably larger than most hospital budgets, just as a group. And Dr. Rossi is here this evening. I'm sure he'll participate, and has really been terrific in advancing this group. And part of that, though, and here's where the question's going to come in, I need to acknowledge some other very special people here, which are my surgical partners and my nurses. We have Dr. James Wu and Dr. Ted Phillips. I saw Dr. Tim Misselbeck is there, Dr. Sanjay Mehta, Dr. Mike Swerk. So if you need a heart, lung, or esophageal surgery tonight after you, I'm not saying the food isn't okay, but if you have any problems. And also our nurses who are here, Cindy and Ronnie and Jani and Lena, and my OR scrub nurse, Beth Frickman, over there, who has stood by my side for 22 years and keeps me in line. So the question is this. All of these hardworking practitioners, we work hard for a Lehigh Valley Practice Group, and we do believe that the future is going from volume to value. And we're doing everything we can to improve the value. But unfortunately, and I'm going to start with Gary, unfortunately, the way we get reimbursed through insurance and other means is still on volume. So on the one hand, we do want to make this shift. On the other hand, we're kind of in this gray zone between fee-for-service, which is how we historically have gotten paid, and getting paid for doing the right things in the right way at the right time, as put out by the Institute of Healthcare. So where do we go with this? How do we go from volume to value and still be reimbursed for the new innovations?
Well, I actually think we're headed there. Capital, and I know other health plans have done some things, Capital has actually entered into several what we refer to as accountable care arrangements. Now, in the healthcare law, there's that terrible, terrible word, accountable care organization, and largely because of how the federal government defined it initially. But the reality is that we're entering in arrangements with providers, and we're actually in discussions with folks here in the Valley and with folks on Dr. Swinford's team here as well, about ways that we can actually do that. So we've implemented incentive payments around quality care. We've also gotten into some very creative arrangements with some other providers that have really kind of jumped in a little bit more so around taking some level of risk. But one of the things we don't want to do is go back to the days of managed care where this becomes a risk transfer. It really needs to be a payment reform. But to get there, you can't kind of flip the switch, so to speak. It has to be something that we work towards. Part of that is making sure we have the right kinds of relationships where there's trust, and I am happy to say I think we have that both here in the Valley and other areas of our region. So that allows us to kind of get to the next step, which is how do we fundamentally get there over time? We can't do it in a way that is going to make it so difficult from a premium perspective that while we're adding this cost, we still have kind of the base, if you will, of the fee-for-service, that it's increasing premiums. At the same time, you know, the providers can't flip the switch the other way and say, all right, great, we're going to take it all on this incentive. So we've got to figure out a way to transition to there, and I think we are getting there. I'm actually very excited about some of the arrangements that we have in place and that we're actually in discussions with putting in place.
Well, thank you, and I'd like to hear Ron. Now, Dr. Rossi has about 1,000 employees, and you have about 12,000. So, and also, if we can bring a microphone up, I don't want to put you on the spot, Mike, but maybe you can chime in. But Ron, how's this impacting the bottom line at the hospital? And then maybe Dr. Rossi can talk about recruiting physicians and staff in this world and employment and how it's all set up.
Well, it's no secret that we're in a disruptive time, and that's part of the disruption is getting from here to there. You know, many people call it permanent whitewater. You know, everything's changing so quickly that it's hard to flip the switch and make this change that quickly. It's where we need to go and want to go, and it's leading the 12,000 to get to the right place. But it's disruptive. You know, the Medicare has changed one of the rules on what is an admission to the hospital. When you come into the hospital now, we have to classify you as either an acute admission or just an observation based on your diagnosis and the severity of your illness. The difference between an acute admission and an observation for reimbursement is about $10,000 per admission or observation. That's a big difference for us, over 50,000 admissions a year. So that's another transition that we're having to undertake is that transition. And because we're working to keep people out of the hospital and because of higher deductibles and because of higher copays, our acute admissions since about February are down 4%. Our observations are up nearly 10%. So you can do some of the math there and see that that creates some of that disruption as we get there. It's why we employ 10 change management specialists, organizational development consultants, and 10 lean coaches to help us get through this and help us manage the organization in such a whitewater environment.
Dr. Rossi, challenges that you face, then I know you're spearheading a lot of quality initiatives.
Thank you, Ray. Thank you, Ray. Thank you, panel, for a wonderful conversation tonight. And at the end of the day, as physicians, as healthcare providers, as health systems, we have one thing in common, and that is we're human. And so what do humans do in times of stress, when there's anxiety and uncertainty? We get together. We get together because we know that there's strength in numbers. And so as a result, when we talk about recruitment and the changing dynamics within the healthcare workforce, there's significant growth within the employed model, where physicians are aligning with hospitals and health networks to try to be synergistic in what we're able to accomplish with the resources that we'd otherwise be limited. And the ability to invest in the continuum of care, to do some of the wonderful things that Ron has pointed out, is really because of the resources that we have available. And we're challenged. We're challenged because right now, as Dr. Singer pointed out, we're paid primarily for volume. And we're in this unsteady time where it's kind of like trying to have one foot in two canoes as we make this transition from volume over to value. And at the end of the day, our goal is not to fall in the water. So it is challenging times, but we're on the right path. And it's going to take a lot of hard work, though.
And the key is to pick the right health network, which, as I started this evening, I told you I was very lucky to have. You touched on a couple of you touched on a touchy subject of you know, the health law part of it and tort reform and things such as that. Joanne, where do you see that? Is that, I almost don't really even hear it in all the discussions in the weeks. It was a big discussion a couple of years ago, but I really haven't heard that of late with the health care reform, or are the other issues just too big?
I think it is some of that. I also think some of the states that have tried it haven't shown tremendous results from it. But I think it still has to be on the table. I agree with John, because there's a lot of research that shows that defensive medicine is very expensive, and we have enormously high expectations of our healthcare system. In fact, I guess we all expect perfect results, and if we don't have perfect results, we feel as though there's got to be a big check written. But it is not part of the federal health care reform for sure. Insurance is really covered from a state standpoint, as are torts from a state standpoint, and that's one of the complications of living in the United States, is that 50 different states get to make 50 different rules about it. But I think it'll come back in Pennsylvania again. Pennsylvania has a very strong lobby with a plaintiff's bar. So I think we have more of a hurdle than some other states do, but I think it has to be part of the conversation.
I know a lot of the physicians here this evening have concerns about it. I don't know if Phil or Candy, did you want to chime in, or the microphone back to Phil there? There you go. The microphone right to your right, Phil. Phil Hoff is a attorney in town. You're on.
I don't want to chime in, and I'll regret having done so, but my wife's not here to pull me down. It's a pleasure to be here, and I have the privilege of representing physicians at times who are unfortunately brought into cases where perhaps their malpractice insurance carrier lawyer feels that it would be helpful to have another perspective. And we're on the wrong side, with many people in this room, of some of the cases. Nobody's here to listen to me speak, so I will say that out of every 20 cases that come into my office, we turn down 19. We screen 19 cases, are not paid for that screening, tell people why, although they did not get an ideal result, that does not mean that the medicine was not ideal. If we accept that case, we have to hire a member of the medical profession who usually charges from $5,000 to $15,000. And that medical professional in the same specialty has to prepare a certificate of merit saying that there is merit to the case to go forward. 8 out of 10 verdicts in the Lehigh Valley are in favor of the medical professional.
Candy Heimbach, the defense attorney, is applauding.
It would be 50-50 if Candy were not defending these cases. Candy Heimbach. One concern I do have, people who come in where a physician has made an error and says, I think you need to be paid for this error, in so many words, because you've lost 3 months of pay, and that is something that was an admitted error with the wrong drug or whatever. There's no way to address that easily and cheaply without getting a lawyer involved. And because there's this threshold of having to hire a professional doctor to be a witness and all of this, it's a shame that there isn't a more civilized way to address these things. So I really feel that good lawyers are healers, good doctors certainly are. I never put myself in the same class, and I appreciate your allowing these unexpected words.
Thank you, Phil. You know, and a little story about Phil and me. We got to testify in front of Lisa Buscola years ago, the state senate, on tort reform. And I got up and said that I always wanted to be a doctor. I played with there's reels of Silent 8 movies from the 1960s showing me examining everyone in the family with the play Doctor's Kid. And Phil got up next and said, well, you know, I always wanted to be a lawyer since I was a kid. I grabbed the microphone in front of me and I said, yeah, well, I don't know any play lawyer kits, you know. And he's never forgiven me for that. Fortunately, I haven't had to go against Phil. So new technology, Chris, costs a lot of money. At Lehigh Valley Health Network this year, we implanted 85 transcatheter aortic valves. On the one hand, you don't need to use the heart-lung machine, and it's being prescribed for patients who are otherwise too high risk for conventional surgery. But each one of these valves costs about $25,000, and that's just the valve itself, not even the hospitalization. These are patients who probably wouldn't even been given an operation. Now they're being given an operation, and they're being given a very expensive one. How do we get around the fact that a lot of new technology is expensive?
Well, it kind of goes back to the approval process, the development timelines, and the tremendous failure rate in the innovative industry. So the amount of time it takes to get a device from early discovery or development, from invention through the approval process and ultimately into the hands of a physician can be up to 10 years and can cost north of about $100 million. And if you fail along the way, those are all sunk costs. On the prescription drug side, the numbers are even more dramatic. With prescription drugs, it takes about 10 to 12 years to get a drug from discovery through the approval process, and can cost between $800 million and $1.2 billion on average. And again, if you get halfway through the approval process and that drug fails, those are sunk costs. So a lot of it has to do with recouping sunk costs, recouping losses, and being able to invest in the next innovation and constantly improving the innovation. I think we've talked about value, and we've talked about the importance of using innovation to bring down costs. A lot of that has to be encouraged with appropriate IP protection, with appropriate regulatory enforcement and processes. There's tremendous uncertainty now in the medical device community, in particular at the FDA. We're not looking for guarantees that devices or drugs or biologics will be approved, but we need more certainty in the process. Unfortunately, what that's led to is a lot of device companies in particular have started to take their new technologies to Europe first for approval and ultimately for use by physicians, not because the European regulatory or approval agencies are easier, but they are more predictable. The FDA continues to move back the goalposts, and that incurs costs. They are incredibly risk averse. Everybody wants patient safety, but there's no incentive at the FDA for innovation or for advancing technology. It's mostly about protecting the FDA for when there is a problem. So I think there's a cultural issue at the FDA. that leads to uncertainty, that leads to length of process for approval, which is incredibly costly.
Now, you know, it's interesting you mentioned Europe, and it's true, the so-called transcatheter percutaneous valve was first in Europe. Many of these things are first in Europe or even Canada. And the thing that strikes me about that is that most of those healthcare systems are what we refer to as socialized medicine or national health insurance, and I'm wondering how they can afford it. And this is going to be my last question, then we'll open up for the audience. And I'm just dying to ask every single one of you, and we'll go right down the line. My thought is that maybe all of this, Patient Protection and Affordability Care Act, you know, referred to as Obamacare, is really a stepping stone between what we had before and national health insurance, or people refer to as socialized medicine. And I'm trying to scratch my head and get around that. Is that a good thing? First of all, question, do you think that's a correct statement, that that's where we're heading? Is that a good thing? We've kind of been told that it wasn't a great thing in Canada, but Canadians seem to be doing okay, and certainly we know in Europe they're doing okay. What do you think? Is it coming? Is this just going to be so painful that that's an inevitable next step? And is that a good thing? Joanne?
It is definitely not coming, in my view.
Okay.
Americans are built on a capitalistic framework that I don't think we would ever accept that. I mean, one of the things I noticed when I spent time with the NHS is people were very accepting of the fact that they had to wait. I met a woman who was a director of nurses in a hospital, and she was on crutches, and I asked her what happened, and she said she tore her knee ligament, whatever part that is, skiing. This was in July, but she wasn't in line for surgery yet. But she was okay with waiting because she felt that there was a safety net issue there, which I don't discount. But I don't think it's going to happen. I think we have good insurance companies and good provider systems that the laws will help them to work together. But I don't think that people will be in favor of a government system because we aren't that crazy about the post office.
John, what do you think? Is it coming?
You know, I honestly don't know, not to bail out on you here.
Not to be the weatherman.
Yeah, not to be the weatherman, but yeah. I have wondered myself if a system like England's is such a bad thing when you look at the ability to provide for the government to control the cost. So ultimately, if they just said, we'll expand Medicare to everyone and provide basic levels of services, use the established insurance companies to manage those programs, and then allow the public to purchase insurance products on top of that. You know what? It's radically different than what we have, but if we had the opportunity to draw it up on a blank piece of paper, it doesn't sound so bad to me. But I think getting from where we are right now to that would be, this is painful what we're living through now, that would be just excruciating. So I don't know how we would get there.
And I guess the question is, as we go down this path with Medicare and Medicaid and the newer insurance exchanges, I wonder how radical it really will be, I guess, is part of my thoughts. So, Chris,
Yeah, I
I
agree
can
with,
guess your answer, I think.
well, no, I agree with Joanne that I don't think it's going to happen, although I do think we're headed toward a hybrid. But the reason I don't think it'll happen is because of the market-based system that has made the United States the world leader in healthcare delivery. It's also, we're also the world leader in innovation. And once the pendulum swings too far toward government running and managing costs and prices, innovation is going to start to drop off. Employers are going to start cutting employees, certainly in the innovator industries, and there's just going to, people are going to vote with their feet and eventually turn it around. Sometimes I've often heard from Washington folks talking about Medicare, government-run program, hugely successful, seniors are happy with it. Well, the reality, and I'll put my former Blue Cross Blue Shield hat on, that was made possible because of the Blue Cross and Blue Shield network around the country. That is not an exclusively government program. It's really because of the private market that we have that that's even possible.
Gary.
Well, and I'm not going to necessarily make the prediction. I've been married 25 years, and I learned predictions don't work. I'm always wrong. And
I was going to say that I can predict that I'm always wrong. So,
but I will say I think we're starting from different points. I would also point out that as while Medicare is a wonderful program in terms of providing that safety net, I think there are people that would talk about how one of the reasons we kind of have some of the cost issues we have is because the largest payer in the system by far is the federal government. And I don't know that anybody is happy on the provider side with how the federal government has handled its payments over the years to providers, and as a result, as it flows through our system. And what happens is the costs then shift to the commercial side. So if you look over time, I think that there are certainly challenges associated with that kind of system. I think we're also starting at different points. If you think about England, if you think about Canada, you think about their cultures, where they started, they were at different points when they entered kind of this fray. And I think there is a lot of acceptance, if you will. We did a forum, now it's 2 years ago, where we had somebody come in and speak on this, and we had employer groups from all around the region, and there were actually some folks that were from England. There were 3 people from England. There was 1 person from Switzerland who got up and spoke and said, you know, we don't particularly care for what it is that we have, and for the very reason was around the wait. When you know, to go in and see a specialist. I don't know if anybody knows in Massachusetts, but Massachusetts is one, you know, in Boston especially, you really have a concentrated area of some really high specialist providers, some very well, you know, known specialists in their field. You have Mass General Hospital, you have Brigham and Women's. And the wait time to see a specialist prior to their reform, I think, was something on the magnitude of like 19 days. After reform, today, that wait time to see a specialist is almost 60 days. And it's actually each year it's continued to creep up, because as you build the ability for more people to come into the system, you have that access crunch. So I'm not sure where it'll go, and there's a lot of positive things to come out of what needs to happen and what's happening out of reform. But at the same time, I don't know that you can kind of compare the two.
Ron, and as you touch on this, Ron, can you maybe explain some of your vision with the Allspire project that we're working
Sure.
on?
My answer is yes. Did you want me to expand on that?
Yeah, that's good. Was that yes to my new contract?
As you know, Ray, our medical staff leadership consists of President-elect, President of the medical staff, and immediate past president we call Troika. I asked them that same question Monday afternoon. How many years till we have a single-payer system in the United States? One said 5 years, one said 10 years, one said 15. I think it's just a matter of when. But in deference to the comments made by JOANNE and Chris, I think we will have a more robust 2-tiered system. And to take care of those 50 million uninsured now, that's going to be the single-payer system. I don't know when, may not be in my lifetime, but I think it will.
So you feel it is
eventually,
inevitable?
Eventually, we'll see that.
And is that simply because we just don't have the money to pay for everything as it stands today? Or I guess, why do you feel it's inevitable? Because it was 4-to-1 here.
Right. I think it's inevitable because I don't think Obamacare is going to work. I endorse it. I'm supporting it on the triple aim, but I don't think it's going to do what they intended it to do. Might even get undone in the next session of Congress. And we are going to have to find a way to care for that mass of uninsured in some way, and we can't do it the way we're doing it now. We can't afford it. But the people in this room are affluent enough that you won't be affected. That's why I say we're going to have a much more robust 2-tiered system of commercial payers for people who can afford it. Most of us won't be affected by the single-payer system.
Do you want to touch on Allspire?
Well, I'll just mention it. Allspire is our consortium of 6 other health systems of comparable size to ours. It's WellSpan out of York. It's Lancaster General. It's Reading Health System. It's us. It's Atlantic Health System in New Jersey, Hackensack University Medical Center in Hackensack, and Meridian Health System on the northern Jersey shore. again, working together to try to solve some of the conundra that you've heard described tonight, and believing that each of us have unique assets, intellectual assets, to help the other get there, so that comparable functions, our CMOs have a meeting planned in the very near future. Our CIOs will be meeting together on Monday. You know, it's partnerships again, as I alluded to earlier.
Are there any questions from the attendees tonight, the audience? Please, in the back.
Yes, question I have actually, I'm Dr. Mary Fabian. I'm a doctor in private practice in South Allentown. Dr. KRISTEL really hit hard the high deductibles. It's going to hit all of us. Don't be aware, it's going to hit all of us, not just the people that are uninsured. And people are going to be shopping, and they're going to be finding out where the best deal is. What are the health systems going to do? They're socking people with these facility charges that are above and beyond what their insurance is paying for. As our director of Capital BlueCross knows, that they've been having to pay out those claims on top of the claims that are already submitted by us as physicians. People are not going to stand for this stuff anymore. They're going to be looking around. What are we going to do? How are we going to address these people? Because if their deductible is $5,000, they're not going to go someplace where they get socked by a facility charge of another $1,000.
Gary, what do you think?
Well, I think one of the things that you're going to see more of, and you're seeing more in the marketplace now, is transparency. As people have these higher deductibles, you know, whether it's a facility charge or even putting aside some of the what I'll call the procedures that you would normally go to for an outpatient surgical facility, put aside the physician, some of the other things like diagnostics. I don't know if people understand, you know, the range there, but, you know, you could go to any different diagnostic center, depending on where you go within even a certain radius, and see charges that range anywhere from $800 to $3,500 or $4,000. And yet it's generally the MRI, and then, you know, of course, it'll be read by a physician. And so what you're going to see with these high deductibles, people are going to have to be empowered with information in order to determine what's the best value for my money. They're going to have to see transparency where there might be facility charges to say, well, if I go see a physician in this particular group, I'm going to get hit with a facility charge. If I go see a physician in this other group, then I won't. Then they're going to have to decide, is that, you know, is that worth it for them, depending, again, on how they're looking at quality. So a big part of this is really being able to put information in the hands of the consumer. Now, that's not an easy thing to do. There's a lot of data out there. There's a lot of differences of opinion on what constitutes quality. I'm not a physician, so I wouldn't begin to tell you what constitutes quality in that regard. But it is something that people are going to have to be empowered with more in order to make some of those decisions.
We are running a little over, so we're going to take one question. And was it Dr. Feldman? You had a question? If we could get a microphone to him. And then we also have gifts for our speakers. And would the two future Singer College students want to come up and hand the gifts? You can work your way up here. And
Raymond,
go ahead, Bruce.
I wanted to thank you for acknowledging the youth, the young people who perhaps are dreaming of become physicians in the future. Because when we ask the question, what is the future of medicine going to be, it lies with them. And so I would like to ask this question because I fundamentally believe that the essence of medicine, of what we do as physicians every day in providing compassionate care, doing our best to prevent illness and maintaining high quality of life, and struggling with the management of people who are suffering with pain, who are dying. I'm curious from the panel's point of view, how do you entice physicians of the future to want to be physicians, given all that you've said?
Ron, maybe Joanne. Go ahead, Joanne.
I think there's enormous opportunity for people who want to be physicians going forward. We have a baby boom generation that's going to explode with needs in terms of how big it is, and the shift, I think, is going to be that there's so much demand in primary care, which we have not done a good job of reimbursement to line it up with people wanting to be primary care physicians. But I think that the Affordable Care Act, through the law or through what's going on around the law, will shift that somewhat so that people are more encouraged. But I think the opportunities are really limitless, and it's going to be an exciting place for physicians because physicians are largely going to have much more control over what happens to patients than they do today, in my opinion.
Ron, John, you wanted to say something?
Sure. I would just say for any of us who have chosen a career in healthcare, I think we've done so because it's a calling. It's a special calling. And the only way you know that is to be exposed to it, which I likewise applaud the efforts of this college to expose so many of its students to the field of medicine so they can see whether or not it calls out to them. There's no doubt about it that if you answer the call, there's not a single day you go home and you don't say to yourself, boy, I did something today that was just wonderful. And yes, it's challenging, but it's still that calling.
And Ron, you're teaching a lot of future doctors, so.
There's never been a better time to be in medicine. And the reason is because the opportunities are so much greater now. And you all have, I say that from Missouri, you all have the technical skills with what you do that we criticize, we old people criticize, and I say this to the select students that are part of our USF program. You need to teach us how to harness up this technology to use it. A futurist I just heard in California a month ago talked about the millennial generation and how wonderfully talented you are. And the reason is because you can assimilate so much information from so many directions so quickly and reach a conclusion much quicker than we did in our comparable ages. And you'll be able to do that. With our select program, we also are looking for what was just described by John. We're looking for people that are called to do this. You go through the admissions process, and yes, you have the technical skills, the grade point average, maybe not a little raise, but you have the grade point average to get admitted, and then we put you through an emotional intelligence interview to see if you have self-awareness, to see if you have self-management, to see if you appreciate the fact that you've had failures in life and what did you learn from those, and other issues that tell us it is a calling, not a financial calling. It's a calling to serve and take care of people. I orient every one of our 12,000 employees as they come through the door. I participate in that orientation. We're in the middle of, I just did my 15th employee forum this morning, and my statement is just what John said. Anybody that works in healthcare, and it doesn't matter if you're a caregiver or a janitor, a valet, a carpenter, a nurse, whatever you do, people that work in healthcare are called to do it, and we do it because we make a difference in people's lives. We don't make widgets. We serve people, and we make a difference in their lives. There's never been a better time to be able to do that than there is now.
That was just so beautifully said, Ron. And when we started this evening, we said that college was a place where dreams began, and hope for the future, hope for our children, and for my children. And what a nice way to tie it all together. I want to thank the panel, and if you want to grab the gifts for each of them. And I want to thank all of you for coming here this evening and sharing in this experience. And thank you for your support of Muhlenberg College. Good night.
Nice to meet you too. Very nice. Well said.
It was great to meet you, Chris.
Workers here